So, welcome everyone to this edition of the Emergency Medicine Foundation Kenya monthly CMEs in collaboration with Daktari Online. I'm Dr. Effie Wambui. I'm an emergency medicine trainee resident here in Nairobi. And today I'll be taking us through clinical reasoning in emergency care. Something very quick, very sweet. I'll be talking about critical thinking and how we apply that to emergency care. And we'll just talk about the clinical reasoning cycle and how you can apply it to your daily emergency care. So to start us off, what is clinical reasoning? So it's a series of complex cognitive and metacognitive processes that are essential to evaluate and manage a patient's medical problem. So in a nutshell, cognitive processes are those thinking processes that are based on the knowledge of aspects of clinical care. So these skills are learned through just reading and applying, your health-related literature. And these skills are enhanced through just critical thinking and just applying whatever you've learned during your patient encounter to your next patient who may present the same way or, just generally in your general management of the patients. Now, there are like two accepted cognitive theories. It's actually referred to as the dual cognition theory. There are two interactive cognitive pathways that usually just underpin our human decision making. Now, the first one is the system one. This is the fast, automatic, and more or less intuitive, thinking process, where the moment we hear a patient has, let's say, for instance, this central crushing chest pain radiating down their left arm, and like, aha, patient probably has an acute coronary syndrome. And it's something that you don't need to think about it. It's at the tip of your tongue. It's at your fingertips. You already know this patient has this. This is what I'm going to do. But there are other times, life throws you a curveball and you get a patient where, okay, I don't like to call it this, but Hapanapala syndrome, where they come with these weird amorphous signs and symptoms, and you're not entirely sure what this patient might be having. And this is where system two kicks in. And that is the slow, more deliberate, methodical, analytical thinking process. So in this case, you have your patient and they've described to you how they're feeling. And in this case, you've developed these hypotheticals. So you're like, okay, what does this patient have? And you have your list of differentials. And during your interview with your patient, so you're taking your history, you're doing your examination, and you send your patient out for your investigation. You're sort of like testing your hypothesis. What does this patient have? And based of what I found during my examination and what I found from my investigations, how can I manage this patient? Now, when it comes to metacognition, it's essentially thinking about thinking. So we're basically just interrogating why we thought a certain way and how our thoughts influenced whatever decision it is that we made. So lots of things will influence this. So our emotions, our experience, our surroundings, they all will affect how we think. So basically, metacognitive processes are just basically the skills you've learned while you're caring for your patient. So that is essentially what clinical reasoning is. Now, what does it entail? Now, it will entail your clinician knowledge. You can't draw from an empty well. So we need to develop a wide knowledge base so that whenever you're thinking, okay, what does this patient have? You already have your list of differentials. And this is based off of the symptoms they're having. And this is something you derive from your history taking. And this knowledge base is something that we've already started building from the moment we're like in our third year of medical school. So all those clinical sessions we've been having, those were all in a bid to build that knowledge base for you to be able to at least correctly diagnose your patient. Of course, this knowledge has to be evidence-based. I hope we are all practicing evidence-based medicine. And then it also entails application of biostatistics and epidemiology. So you have to really take into account your patient's background. And, I'll give you the example of a patient who has jaundice. And if this patient, for instance, comes from an ethnicity in Western, I'll already be set down a different thought trajectory versus a patient from, let's say, Central region presenting with jaundice. So you also have to take into consideration where your patient has come from. And also when you're applying all these studies that are out there, you have to take into consideration what sample population was used in this paper. I mean, for instance, you can't take a paper that was probably looking at, let's say, the management of hypertension in 15-year-old Caucasians who would have a completely different etiology to their hypertension, and then applying it to the 80-year-old African man that is sitting right in front of you. So you really have to take into account the biostats and the epidemiology, basically the background of your patient. Next is consideration of cost. Now, will the investigation you choose change your mode of management? If not, why are you asking for the test? Remember, these tests cost money. And even before you start sending your patient for all these imaging or laboratory tests, just them coming to you for your expertise, that is a cost to them. So you want to really try and mitigate the amount of financial constraints you're subjecting your patient to, and just order the tests that are required for you to make as close to an accurate diagnosis as you can. And then next, you have to take into account your patient's values. One of the 4 tenets of patient bioethics is autonomy. So whatever you found in your investigation, whatever you found, what you think could be the issue with the patient, you need to communicate that with them. And based off of your findings and what you think the issue is and what you want to institute as your plan of management, you need to communicate that to your patient. They have to be okay with your plan of management for you to go ahead. So the patient's values, and this also ties in with communication. So the communication isn't just with your patient and their next of kin or their relatives. Emergency care is a team effort. You have to be in constant communication with the nurses you're working with, the rest of your team members, your consultants, and even from the moment the patient is brought in by the paramedics, the chain of communication begins from there all the way to the patient. So that brings me to critical thinking. What is critical thinking? So this is the process of intentional high-level thinking to define a patient's problem, examine the evidence-based practice in caring for the patient, and making choices in the delivery of care. So it involves that differentiation of statements of fact, judgment, and opinion. So when it comes to critical thinking, there are no feelings. It's not what your lecturer taught you in undergrad. Okay, well, I'm not saying we completely disregard that, but it's what is the standard of care. It's not what you've been seeing being done. It could not be the standard of care, but what is the standard of care? Like, if someone was to come and interrogate, someone not from your facility was to come and interrogate how you manage this patient, does it fit the usual standard of care? Here, your opinion does not matter. It is fact. So it's critical thinking is that metaphorical bridge between your information and action. There are certain affective components and cognitive components that come into play when it comes to critical thinking, and we'll touch that when we talk about the circle model of critical thinking. Why is critical thinking important? It helps to improve decision making. Once you've managed to diagnose a patient, if you have these standards of care, these algorithms that are evidence-based, then you'll not be able to start deviating from the standards of care. Your decision making is already a set way that you should be, sort of thinking a certain route you're supposed to be following. It enhances problem solving ability, and this will tie into creativity. For instance, if you understand the principle behind why you're using an underwater seal for your patients who've undergone a tube thoracostomy, I don't know whether this still happens, but there were stories when I was in undergraduate that, there are some facilities that don't have that proper, a commercial underwater seal. But because of that background knowledge of the principle of how an underwater seal is works, you're able to, make your own makeshift underwater seal. So you're able to be creative, you're able to be flexible, you're able to problem solve. It also helps you refine your research skills. Once you're able to sit down and you're able to analyze how you managed a patient, and if there are any gaps in the standards of care, then you're able to be like, okay, how can I bridge those gaps? Now, this brings me to Alfaro Lefebvre's four circle critical thinking model. So this Venn diagram, basically all those competencies and characteristics all work in tandem to help a person develop their critical thinking ability. So going clockwise from above, you have to develop your personal critical thinking characteristics. So if someone has the characteristics of a critical thinker, the rest of the competencies and skills in the other circles will just come readily. Now, remember when I talked about the affective components and those cognitive components? Now, this is where they come in. So there was a study that was done I think it was in 2000, where these 10 affective components were derived from this study that was conducted internationally. And there were these nurses from about 9 countries that came together, and they defined these 10 habits of which constitute the affective components. So basically, it's just confidence, being able to be creative, flexible. You're able to be inquisitive, intellectual integrity, intuition, contextual perspective, open-mindedness, perseverance, and reflection. And the other 7 skills when it comes to the cognitive components are like applying standards, discriminating, being information seeking, logical reasoning, predictive skills, and transforming knowledge. So those are some of the characteristics that someone who's developing the critical thinking ability should have. Next is that you're supposed to be able to acquire this theoretical and experiential knowledge, as well as these intellectual skills that relate to critical thinking in a particular situation. So in this case, you have to take responsibility and seek out these learning experiences to help you get that theoretical and experiential knowledge. So just in this case, it's just a lot of practice. So in as much as practicing these hands-on skills improves those hands-on skills, you need to also keep practicing these thinking skills to be able for you to improve your critical thinking ability. You need to be able to gain interpersonal skills, because like I said before, emergency medicine and emergency care in total is a team effort. You have to be able to work as a team. You have to be able to manage your emotions and get along with other people who, we all have different personalities. So you have to be able to also give constructive criticism, because even when it comes to developing critical thinking, we all contribute to each other's critical thinking ability. And one of the ways we're able to develop each other's critical thinking abilities is criticism. This is, you did this the wrong way, you should have done it like this. Next time, watch out for A, B, C, D, E. Next, if you don't have the relevant technical skills, you'll have to, it's more like a brain drain. Instead of being able to now apply that critical thinking, applying those skills that you have, you'll be spending more time trying to develop those competencies. So one way to be able to use this circle model to, develop your critical thinking ability is just go in each of those circles on the Venn diagram and write out the skills you want to work out. And then just sit down and practice. So with all that being said, in short, clinical reasoning is just the integration of critical thinking to the clinical situation. Now, there was this interesting study that was done in 2020 in the UK, and it was basically looking at how junior doctors in emergency care approached clinical reasoning in terms of patient care. And they came up with this interesting model when it comes to how they approach the patient. So I'll just take it through you, and I'm pretty sure when I go through it, you'll be able to pick out like, this is probably how I also manage patients. And this is this is going to be seen in people that don't have that much experience in the ED or in emergency care, or people who are new to emergency care. So the first part was case framing. And when it comes to case framing, this is where you're being able to discern, is this patient presenting to me with an urgent or emergent condition? Is this a patient that I'm going to manage inpatient, or I'm going to let them go home? So when it comes to case framing, we first take in those initial cues. And those initial cues might be the information that we get from the paramedics. They've brought a patient in with such and such symptoms. Or it could be from the nurse who's triaged the patient. And then when it comes to the first impressions, is that, when you've gone and you've peeped through the curtains and you're having a look at the patient, what's your first impression of this patient? Are they sick looking? Are they fair looking? That sort of thing. So you're able to sort of case frame. And this also comes in with, for instance, when you're given a certain symptom that this patient has. For instance, I'm more inclined to be like, okay, this patient might be a bit more on the urgent side if it's a 40-year-old that's coming with chest pain versus a 15-year-old who's coming with, I don't know, toe pain. Yeah. So after case framing, we move into evolving reasoning. And this is now us trying to figure out, okay, what does this patient have? What is their diagnosis? So in this case, remember those two cognitive processes we talked about earlier? The first intuitive one versus the slow methodical one. This is where they apply. So for recognition, sometimes we'll get that one symptom, just that one symptom, and you're like, aha, this is what the patient has. For instance, like I'd mentioned, just get a patient with this crushing central chest pain radiating down the right arm, and you're like, yeah, this is probably an ACS. Or it might be just a pattern, and the patient might just come in with abdominal pain. They're like, doc, I have this abdominal pain. When I sit up, it feels much better. And oh yeah, by the way, in the weekend, gone out with the boys, there's some, we drank a bit, and we're like, aha, this patient might be having a pancreatitis. So that's where we have that instant recognition. But there are times, again, like I told you, you're thrown a curveball and the patient comes with completely amorphous signs and symptoms that, we're forced to have that slow, methodical thought process kick in. And for instance, this will really show when you're dealing with patients that, you're not that well versed in managing. And a lot of times it's on the pediatric side, if you're not used to managing pediatrics, or even the more elderly patients. Sometimes they'll just come and tell you, oh yeah, my 85-year-old dad for the past 4 days has just been dull, just not been themselves. And you're like, okay, that's not much to go off for. So you'll need to sit down and now think. And that's where your hypothetical deduction comes in. You're trying to develop a hypothesis and you're trying to rule in and rule out what the possible diagnosis could be. Now, this is where heuristics and symptom chunking come in. Heuristics is basically these mental shortcuts that you develop when, when you've experienced if you've managed a certain patient group, or you've managed patients with a certain symptom, you're able to just quickly rule in and rule out certain diseases. And this comes with experience. Sometimes patients might come with so many symptoms, and this is where symptom chunking comes in, where you just take a symptom and you're like, okay, how is this symptom? You really delve deep into it. For instance, if it's pain, you will Socrates this, you will go into your associated symptoms and keep branching out as you try and rule in and rule out your differential diagnoses. Now you will do that until you reach a decision-making threshold. They're like, okay, fine, this is what I think the patient might have, or you might want to send them out for further investigation. But there are times, even after all that, you're still not sure what's going on. So sometimes, what do? You might want to expand the clinical encounter. Now, I know in the emergency department, you might not have that space because having patients there for a long period of time, you're taking up space for, other patients, and you need to quickly clear patients, but sometimes expanding the clinical encounter might help. And in this study, they saw that expanding that clinical encounter to about 4 hours helped a lot. Because that time you're able to see other patients, and that might kind of reset your brain so that you're able to, to think like, okay, what did I miss out while I was examining this patient or when I was interviewing this patient? Sometimes you might want to share the responsibility for decision making. You might want to consult a senior colleague or a consultant. And sometimes you're like, you know what, it is what it is. I need to make a decision. And you'll be like, okay, am I comfortable letting this patient go home? Or should we just have the patient be admitted for further investigation? And after that, you reach your decision-making threshold. So I don't know whether that's how a lot of you find yourself dealing with patients. I know this summarizes me pretty well. So now here comes the clinical reasoning cycle. Now, this is actually derived from a lot of nursing literature. So there are these different phases of clinical reasoning where, let's start from the top. I think it will make more sense if I give you like a clinical scenario. So for instance, you have this 8-year-old hypertensive, comes in with abdominal pain. So in this case, you want to consider the patient's situation. At this point, you're trying to gain an initial impression of the patient. You're trying to pick out the salient features. You're trying to really find out what brought this patient to hospital, what are their complaints. So next you come in to collect your patient's data. So you want to review the current data, and this might be now the handover information you've gotten from your paramedic or from your nurse, your triage nurse. Sometimes if you have your electronic health records, you can be able to pick out the patient's history from that. And then, for instance, in our patient, you might find that, oops, their last clinic visit was 10 years ago. And if you even delve in deeper, the paramedic had asked the relatives on their way here, has this patient been taking their medication? And they're like, oh, no, for the past five months, 10 months, they've not been taking their hypertensive medication. You might also want to gather new information at this point, and this can be your preliminary information like your vital signs and your sample history. So probably in this hypertensive and you've done your vital check and this patient is not exactly hypertensive at this point. Your BPs are on the floor like 60-40. Next, what you want to do, you want to process this information. So you want to interpret the cues that you've been collecting, and then you just interpret them in the context of your patient. At this point, you might already have your preliminary diagnosis. You're like, okay, maybe this patient might be having a ruptured abdominal aneurysm. So in this case, you want to have your diagnosis in order of the most life-threatening or organ-threatening or limb-threatening to the least likely or the least emergent. So in this case, you want to identify what's the problem in this case. What's your issue? The issue is you have a hypertensive with BPs on the floor with abdominal pain. At this point, what do you want to do? You want to set goals. What do you want to happen at this point? What's your desired outcome for whatever it is that you want to do for this patient? And what time frame should it occur? So let's say in this case, we're like, okay, we need to pick up this patient's blood pressures. And if we're thinking if it's a ruptured AAA, we want to maintain this patient's BPs more or less on the lower side. So SBP 70 to 90. What will I need to do for that? I need to give them some volume expansion. With what? With blood. So at this point, I want to take my samples to the lab for grouping and cross-matching or whatever it is. Maybe at this point, I also want to do a point of care ultrasound. Is it really an abdominal aneurysm at this point? So you want to establish goals and then take action. What do we need to do to achieve these goals? So at this point, you also need to pick out who is the one who's the best placed to carry out whatever action plan it is. So you want to put in your lines, you want to rush your samples to the lab. Someone who's well-versed in POCUS can come in. If not, you can get someone from the radiography side to do your point of care ultrasound. And indeed, if it's an AAA, you want to call in your vascular surgeon. At this point, if it's a AAA, you want to take this patient to theater. Make sure by 90 minutes from the patient encounter, they are on the table. So these are things that should be running in your mind concurrently, systematically. And then once you've put in place your goals and you've already set them in motion, you want to evaluate the outcome. Now, where are my patients' BPs at this point? Are we doing well on our BPs? Do we need to escalate this patient further? Again, also, does this patient need to be transferred elsewhere? Those are the things you need to be thinking about constantly. If you're not getting to the outcome you desired, you can always reflect and go back down the whole cycle. So this cycle is not at okay, we've reached a reflection point. What did we do well? How can we improve? What we have done differently? And then we say, okay, fine, story has ended. You have to always keep reassessing your patient. What is your patient's current situation? Collect data. What are their vitals right now? What is the based on how the patient is presenting and the data I have, process that information. Is there any problem we need to troubleshoot? Set goals again, take action. It's a constant cycle. When it comes to emergency care, I would say it is a bit different. I'm sure Dr. Washira will comment on this later, but it's a bit different with general medicine and how we approach our patients. It's a complex activity. I read somewhere that emergency care practitioners are like, we're running in a circus where we are balancing all these plates and balls all at the same time. We have so many demands from different people, from administrative personnel, from our fellow colleagues, from patients and their relatives. We are always being bombarded by lots of information. And there was a study that was done, and just to find out how often our emergency care practitioners, this is in hospital, are interrupted. And it was found that we are interrupted at least on an average every 2 minutes. So imagine you're sitting with your patient and every 2 minutes someone is coming, doc, 1, 2, 3, 4, 5, doc, A, B, C, D, E. So yeah, we are juggling a lot. And then remember, our interventions are usually time bound, and it's just normally quite chaotic. And remember, our patients, a lot of the time, unlike in general medicine, history might be unobtainable. We might not be able to do a proper physical examination, and sometimes we can't do some of the medical investigations we want to do because the patient is critically ill. As opposed to general medicine, we have more or less limited time to make our decisions. Our stress levels are way higher. Our short-term target isn't really diagnostic closure, but we want to make sure that whatever it is that we're managing this patient for, whatever it is that we're doing, it's not we have to mitigate against a threat to life, to organ, and to limb. A conclusive diagnosis can be made later, but we can't make that decision on a patient that's no longer alive. Get what I'm saying? So our stakes are much higher as opposed to in general medicine. And we have a much wider information gap. Remember, sometimes these patients can't give us a proper history, but we have a narrower margin for error. If the patient is crashing, we need to deal with it now. Our work environment is more dynamic and it's rapidly shifting. A patient who came in with a GCS of 15, laughing, smiling, talking, in 2 minutes might be a GCS of 8, and we're needing to rapidly intubate. So we're usually a bit more primed for action than, general medicine. Now, I've spoken about all those nice things, but there's a problem. Like the quotes we have here, human beings are poor examiners, subject to superstition, bias, prejudice, and a profound tendency to see what they want to see rather than what is really there. So what I'm alluding to is biases. So biases are just these ingrained assumptions, prejudices, stereotypes, and preconceptions. sometimes it is what it is. We might overlook or misinterpret the significance of this cue, or we jump to conclusions, or we might fail to take into account other possibilities. And, we might not be entirely aware of these biases. And sometimes we might not be aware of how negatively they influence our clinical reasoning. So, what are some of these biases that we may fall prey to? The one that I will also say I've fallen prey to, and I've seen a lot of colleagues fall prey to, is anchoring. So this is just that tendency to lock onto into those features a patient may present with, and failing to adjust this impression, despite all the confounding evidence against that. So, for instance, you might come and a nurse might say, "Oh, by the way, doc, tukona patient akona DKA, or a patient akona pneumonia." So you've already had that idea or notion in your head that, this patient has pneumonia, and you will always be looking for cues that point towards pneumonia. And probably this patient doesn't even have pneumonia. Probably it's just having an asthma attack. And you're just looking at them, looking for, you know what? Let's do a rest biofire, or let's do cultures. Let's find out what is causing this pneumonia. And the patient might just be having a reactive airway or something totally out of left field. So this anchoring is normally compounded by another bias that a lot of us have fallen prey to, and this is confirmation bias. So we've already locked onto this diagnosis that a patient has. So we're going to look for supporting evidence that will support this preconceived diagnosis, rather than looking for something that will disapprove this diagnosis. So you're like, this is pneumonia and it will not be anything else. So you'll run all these tests, and that small positive finding will be like, I knew it, it's pneumonia, despite all the other evidence that is pointing against it. Sometimes, we might have some ascertainment bias where our thinking is shaped by prior assumptions and preconceptions. Like for instance, there's a story I'd read where, there was this elderly patient that had been managed for, I really can't remember what management is, but they'd been bedbound for a while. And it was time for them to start mobilizing and doing their physiotherapy. And the physiotherapist came and came and reported to the nurse that, hey, this patient is in a lot of pain and they really don't want to do this. They really don't want to go through with this physiotherapy. And the nurse is like, they're old. They don't want to do A, B, C, D, E. They just want to be, bedbound and just being taken care of, whatever. But it turns out that this patient actually had a serious medical issue and was actually having a DVT. So, there are those ascertainment biases that we might have based on those prior assumptions that, this is just an elderly patient that just wants to, just lie down, do nothing, and have, everything done for them. But what's the good news is? The good news is that we can mitigate against these biases by being self-aware. We catch ourselves whenever we're tending to lean towards one thing without considering the other possibilities. Practicing mindfulness and being insightful, deliberate reflective thinking. This patient has this, but what else could it be? I saw a patient who presented like this, but it was an atypical presentation. Is there something else that we are not considering? Just that, practicing that reflective thinking, trying to mitigate against those biases, and then always have a healthy dose of skepticism. Even if they come and tell you, doc, pneumonia, you're like, okay, but have you ruled out asthma or something else? Just always have that healthy dose of skepticism. Now, why is clinical reasoning important? Better patient outcomes. If we're able to properly integrate that critical thinking, even if we don't, a patient presents a certain way and we follow a certain roadmap on how to manage them, then we're more likely to have better patient outcomes rather than throwing anything to the wall and seeing what sticks. And at the end of the day, it's the patient who suffers. And if it's not in terms of health, it is financial. Next is patient safety. And this is where those algorithms come in, you know. And other than the algorithms, evidence-based medicine. Remember, one of the things we had talked about when it comes to what clinical reasoning entails is that knowledge base. So if you have that evidence-based knowledge base, then whatever it is that you're doing will always be backed up by some certain evidence. So whenever anyone comes and questions you on why did you do this for the patient, it's because these are the standards of care, and these are the expected outcomes based off this standard of care. And if there are any side effects, we're able to anticipate them and mitigate against them. And again, resource stewardship. And this is just resources, not just in terms of finances, but also human resources. We're able to work effectively, that sort of thing. So in summary, clinical reasoning is a skill to be learned rather than a concept to be understood. And it's always a constant state of learning. We're not all born with clinical reasoning. It's something that we need to do in a constant state of learning. We always have to be engaging those cognitive and metacognitive processes for us to better develop our critical thinking skills. So yeah, that's basically it. I think I'll open the floor to any questions. Okay, I can see a question. Someone had commented on, yeah, it's true about healthy skepticism, but when you're placed like Isli trying to convince a Somali otherwise, it's quite a hurdle. At this, I think I'll just go back to those 4 tenets of bioethics, autonomy. As long as you've adequately explained to the patient, this is what I found from my examination and from the investigations that we've carried out. This is what I think you have, and this is how I think we should move forward. And if we don't do this, this is what is likely to happen. If the patient at that point still does not, doesn't seem convinced, they're also free to seek a second opinion. But at the end of the day, as long as you've done well by the patient, I think it is what it is. I'm with Dr. Washira. What do you think?
I think the main thing about clinical reasoning is making sure that, as you mentioned, you probably are following evidence-based guidelines and factoring in all the aspects. So sometimes it's not just the medicine, it's also looking at other patient factors. The same thing just mentioning, things like cost, beliefs, of course, and there's always the concept around involving the patient in the decision-making.
So someone is asking about an elaboration on the clinical reasoning on a patient with DKA. It's just, basically, I think, let me just open that clinical cycle. So basically, it's just consider your patient's situation again. So in this case, you've been brought in a patient with a diabetic 40-year-old. So that is what you have. You collect your cues and your information. So what is it? This patient has not been taking the insulin, for instance, or their anti-diabetic medication. And maybe if that's not the case, maybe the relatives could be telling you, oh, by the way, doc, they've been having this on and off cough, they've been feverish, and you're trying to gather new information. Like, what's their vital signs? This patient might be tachypnic, or they might be diaphoretic, their blood pressures are tanking. Process the information. So from these cues, what are you thinking? Could this patient be in decay, or could something else be the underlying issue? Identify the problem. I'm thinking this patient is acidotic. I need to normalize their pH levels. I need to stabilize their sugars. So you set your goals. Probably in the next 1 hour, I've put in a certain amount of your Ringer's lactate. By this time, I have to get my potassium levels. I need to start supplementing potassium if I need to do that. Probably in hour 2 or hour 1 or hour 2, I need to start my insulin infusion. And then you take action. At this point, do I need to involve an endocrinologist? Do I need to involve the internist and all that stuff? And then evaluate the outcome. You've done your, what is it, your blood gas, and you're like, okay, I'm targeting this amount of increase of the patient's pH. So, and then keep reflecting. What have we done right? Have we instituted this management on time? Okay, now, what is the patient's current situation? Are they no longer tachypnic? What is the current pH? What is the current vitals? Keep processing the information and identify the current problem. How do we troubleshoot the current problem? How do we now set goals to take care of that problem? What actions are we taking? After that action, what is the outcome? I don't know if that answers the question you've asked. It's basically just, once you've made a preliminary diagnosis and you've run your investigations to prove or disprove your diagnosis, what do you do as per the current evidence-based guidelines to manage that patient? And while you're managing your patient, you always have to have your goals in place, and they have to be time bound, so that at this time I should have hit this target. And then you just keep reassessing